Okay, welcome back. So today we're going to talk about the management of those comorbid conditions we talked about on Wednesday in terms of diabetes and how to deal and treat those in complement with diabetes, as well as treatment of those complications as a result of uncontrolled diabetes. So the first component is, after today, you should, given a patient case, be able to identify comorbid conditions that can impact care for a patient with diabetes and develop therapeutic and monitoring plans for diabetes along with the comorbid conditions. So for this section, I'm hoping to just have discussion related to each of the comorbid conditions and review things that were talked about previously with cardiovascular block. So hoping they'll be able to tell me blood pressure goal per JNC8 and ADA, should be pretty equivalent, as well as if age would impact these, which they should not. As well as what the first-line treatment options should be. I would also like to ask them, based on those treatment options that they mentioned, what things they would monitor for those treatment options. For dyslipidemia, I wanted to just identify what statin benefit group they would fall into, and what the characteristics or descriptions of that benefit group are. Really, since we're talking about diabetes, they all should fall into that diabetes benefit group. And what does that mean in terms of starting statin therapy, and how do you determine moderate versus high? Assuming you're able to get me to, we use moderate versus high intensity. How do we decide moderate? How do we decide high? And then what are our statin options for moderate intensity, and what are our statin options for high intensity, and monitoring as well. For coronary artery disease, patients with known cardiovascular disease should already be on aspirin and statin therapy. However, if they are not, it's something you should be assessing via your ASCVD risk, or if they have coronary artery disease, you know they have clinical ASCVD rather, so they should be on aspirin therapy, 81 milligram aspirin therapy, and the appropriate statin intensity, which being they have clinical ASCVD, as well as a diagnosis of diabetes, would put them at the high intensity recommendation. ACEs should be considered if they're not already indicated. If they have a history of an MI, a beta blocker should also be on board to prevent that cardiac remodeling. We have a little discussion here that there is a stigma to not use beta blockers in patients with diabetes. However, there is really no reason not to, especially if you're non-specific. Your targeted beta blockers. Their management of hypoglycemia, masking of hypoglycemia. Typically, the sweating is one of the symptoms that is not masked, so patients will typically tell you that they may not feel nauseous, or they may not feel jittery, or that they're actually going low. They may just notice that they're sweating versus actually feeling low, as you would with hypoglycemia. So probably at this point, since they will have learned that, the treatments and signs of hypoglycemia from Tom's lecture, I would review that here, asking them to describe what hypoglycemia is and what symptoms they might experience, and then mention here how beta blockers may block those symptoms except for the sweating. Bring up and review that TZDs would not be used in symptomatic or stage 3 or 4 heart failure, and that metformin should not be used unless renal function is stable, which may be possible in someone with progressed heart failure as well. Comorbid depression. Just ask them here a little bit about how they think depression might impact the care of someone with diabetes, and I'm hoping we can get to just kind of a discussion about different factors that might play a role in terms of motivation, awareness of diabetes, care to take care of themselves, kind of talking about all the lifestyle modifications that Chris is going to talk about, and all the daily monitoring, glucose monitoring that they're experiencing with the activity, and how all that might be so much harder for a patient that is working with depression, by thinking about what the symptoms of depression are and reviewing those. And then these treatment options, while I don't have any specific recommendations for patients with diabetes in terms of treatment options, they should have specific discussion based on what they talked about in their previous talks about therapy and counselors, as well as first-line treatment options. Psychosocial issues, so this plays into the depression really well, as sources of the depression potentially including financial, employment stressors, family stressors, eating disorders, anxiety disorders, talking about how all of those and other outside life factors play a role, leading back to things that impact diabetes care and motivation for diabetes care in specific patients. Other mental illness, so outside of the mental illness, their antipsychotics, if they're prescribed, will have an impact on their development or control of diabetes, but having these illnesses and being able to coordinate care for themselves with diabetes is a significant barrier. And also touching on some cultural restrictions, especially if we're thinking about specific foods and fasting and holidays. I'm thinking about our own holidays that will be coming up soon, and how that would impact diabetes control and care, thinking about what you do with your own family and how that might change depending on whether or not you have diabetes or not. So some other restrictions and things to consider when thinking about caring for a patient. The management of diabetic complications. The objectives for this component is to give in a patient case identify potential complications as a result of diabetes, they should be able to incorporate the screening that Chris will talk about, as well as recommend appropriate therapeutic and monitoring regimens for the management of long-term diabetic complications, which they'll be able to apply to patient cases later. So treatment of the microvascular complications, so retinopathy, remember this is the result of prolonged hyperglycemia in the retina of the eye. So optimizing glycemic and blood pressure control to reduce the risk and progression of retinopathy or damage to those blood vessels within the eye. There's two types of retinopathy, a non-proliferative and proliferative. The non-proliferative is characterized as the early stage in the disease when you have mild symptoms and blood vessels are weak but have not burst. So that's when we talked about on Monday that potentially if we get blood glucose under control, patients that might have seen some mild changes in vision may have that resolved. That's the stage where that can occur. Versus our proliferative retinopathy, which is a more progressive form of the disease, there may have some vessels that have burst. The retina is oxygen deprived because of the vessels that have burst, causing the retina to grow new blood vessels that are weak and tend to leak. And you get macular edema, as well as now at risk for glaucoma and other eye-related issues. Treatment for retinopathy includes referral to an ophthalmologist if they have not been seeing one for their screening. There's a laser photocoagulation surgery. This helps reduce the risk of vision loss in patients with high-risk proliferative and macular edema retinopathy. Can you use endothelial growth factor? It's a good question. If there's a drug they would be dispensing, I have to look a little bit more into that. Otherwise, I won't expect them to know that. Even if there is, I wouldn't expect them to know that, but I will include it here just for their information. That's something I'm not sure of either. Presence of retinopathy does not fall as a contraindication for aspirin therapy for cardiovascular risk reduction. Aspirin does not increase the risk of retinal hemorrhage. So that's an important intervention we can make, is if you have providers for a patient that is a candidate for aspirin therapy, but they mention that they do not feel comfortable providing aspirin therapy because of their retinopathy and risk of the hemorrhage of those blood vessels in the eye, use of aspirin does not increase that risk of retinal hemorrhage. Neuropathy. So tight glycemic control is the only strategy to prevent or delay the development of all types of neuropathy, specifically peripheral neuropathy. So review of peripheral neuropathy, what are our treatment options? They should be able to identify these. I think I'll have that blank for them. And then mention to me side effects that you would be concerned, and if there's any monitoring parameters for these as well, and potentially renal adjustments. I would also like to bring up. Autonomic neuropathy most likely is going to be managed by cardiology because the symptomatic tachycardia is usually a symptom of autonomic neuropathy. Orthostatic hypotension, use of compression stockings and Minidrin for treatment of the hypertension if it's severe. Gastroparesis symptoms are often treated early on with dietary changes. You can also use erythromycin as a promotility agent. Metoclopramide for motility is also available for use. However, it is restricted to use for max of 5 days and not indicated for prolonged therapy. And then erectile dysfunctions. I'm not sure where they cover this in the curriculum, but the treatment is the same as it would be if it was just a regular patient experiencing erectile dysfunction with the same precautions in terms of drug interactions, especially if there's cardiovascular issues. Treatment for nephropathy. So some goals for nephropathy is to optimize glucose control to reduce the slow and progression of diabetic kidney disease, and optimize blood pressure control to reduce the risk and slow progression of kidney disease. Annual assessment of urine albumin, which is the urine albumin to creatinine ratio, or the UACR, and the estimated glomerular filtration rate. So albuminuria, or albumin in the urine, is defined as a urine albumin to creatinine ratio of greater than 30 milligrams per gram. I'm not sure if they have heard the terms microalbuminuria before, but I think I might mention here that that term is no longer used, that the range of less than 30, 30 to 300, and greater than 300 is really no longer used, that we just basically treat patients that are greater than 30. So treatment with an ACE and ARB is not recommended for the prevention in patients with normal blood pressure and normal urine albumin creatinine ratio according to our ADA and endocrinologist guidelines. ACE and ARB is suggested for the treatment of moderately elevated, so that UACR between 30 and 300, and ACE and ARB is recommended for those UACR greater than 300 or urine albumin creatinine ratio greater than 300. When EGFR is greater than 60, you want to evaluate, or less than 60, you want to evaluate and manage potential complications for CKD. If you're seeing a significant decline in symptoms for CKD, or significant change in presentation, or rapid decline in estimated GFR, you would want to refer to a nephrologist for management. Management of CKD itself is the same in this course as it was when you covered it in the renal block. Management of complications of CKD would also be a concern if your CKD is progressing through past stage 3. So if you're thinking about complications of CKD, what might a few of those be? Uncontrolled diabetes can lead to progression of chronic kidney disease in a patient that already has chronic kidney disease, and in patients that don't, can lead to the formation of chronic kidney disease and then rapid progression of it. So those complications of chronic kidney disease also can be tied back to diabetes as well, and diabetic-related renal failure. So prevention of the masculovacular complications we didn't talk much about. So treatment of MI, stroke, heart failure, and ulceration are all outside of the course. Treatment of MI and stroke and heart failure you discuss in detail in the cardiovascular block. And then when you get to acute care, you'll discuss how to treat diabetic foot infections, ulcerations, amputations, and those other acute complications that come with prolonged, uncontrolled hypoglycemia. Hopefully we will move into some comprehensive care cases.